There we go with the recording. That please try and keep yourselves muted and feel free to contribute to the chat. And perhaps later, Craig, you probably don't mind if people unmute and just ask questions too. Thank you very much. And so we're delighted today to have Craig Bauman join us. And Craig is a doctor of chiropractic. He's been with the Center for Family Medicine and its mobility clinic really since the inception of the mobility clinic, and as a practitioner, as well as assisting with research as well. He's an adjunct clinical assistant clinical professor in the Department of Family Medicine at McMaster University. In addition to his regular chiropractic practice and mobility clinic work, he does advanced practice work with the regional low back pain program associated with Grand River Hospital in Kitchener. So please welcome a great guy, Craig.
Okay, great. Thanks for the introduction, Joe. And great to be here. I'm always excited to talk about chiropractic care. And again, with my work with the mobility clinic, I have a special interest in spinal cord injured patients. So so next slide. So again, as far as any financial disclosure, I'm an employee of the Center for Family Medicine Mobility Clinic. And I just realized it's my 13th year with the mobility clinic. So pretty amazing stuff. Next slide, please. So as far as an agenda, what I'd talk a little bit is about research regarding spinal cord injury and complementary and alternative medicine, and talk a little bit about that and some statistics, and then focusing on spinal cord injury and pain, and then the benefits of collaborative practice for people, including those with spinal cord injury. Talk a bit about chiropractic and neurorehabilitation hospitals and what's going on there. What happens with a typical chiropractic consult, what to expect, and then the treatments that a chiropractor might use, and then maybe questions at the end for about 10 or 15 minutes, and we'll go from there. So next slide. So yeah, so I had Lindsay do a literature search for me, and I was actually surprised. There is more than what I expected, literature on spinal cord injury and complementary and alternative medicine, and in particular chiropractic. So that was great to see. So I'm going to share some of that research with you. The first paper is from Switzerland, and my background is Swiss Mennonite, so I had to have something from Switzerland. And this study looked at people with spinal cord injury for greater than 1 year. And they found that 74% of the participants had used some form of complementary and alternative medicine. And the top reasons for use were with urinary tract infection, and that was 21 out of 103 participants, pain, and then spasticity. So this is looking at multiple types of complementary and alternative medicine, and including chiropractic. And 2 of the 103 had used chiropractic. So this sort of gives us a bit of an idea of the use of complementary and alternative medicine by people with spinal cord injury. Next slide. And then in the same vein, spinal cord injury and complementary and integrative healthcare, that's basically the same thing as complementary and alternative medicine, just in different countries and in different regions. They use different wording, but it all means the same. And this study was in the United States, and they found that 80% of their 411 patients had used complementary and integrative healthcare since their spinal cord injury. And top reasons for using it, 61% used it for general health and wellness, and then 31% used it for pain. And you know, again, having worked with many patients with spinal cord injury at the mobility clinic, pain is a very common complaint that they have. And so it's nice to see that they're kind of focusing in on this area with these studies. Reasons for discontinuing the use of the complementary and alternative medicine. 42% of the patients stopped. They thought that it wasn't helping. 23% didn't feel that they needed it anymore, so that could imply it was successful, and they found they didn't need it anymore or just stopped. And then 22% found it too expensive. So that can sometimes be a barrier to complementary and alternative medicine, the expense. And I'll talk about chiropractic coverage with extended healthcare later in some of the slides. Just as far as the demographics of the people utilizing the complementary and alternative medicine, they're more likely to be female and live in the Midwest or Western United States, were white, college educated, and a higher income and married. So just that was sort of the trends that they found with these people using the services. 11% had tried chiropractic. And what the study recommended is that rehabilitation clinicians take note. You should have open discussions with your patients about complementary and alternative medicine to ensure it's safe and to reduce any type of medication interactions, especially with someone like a naturopath or something like that. You have to be very careful. So the lesson here is, have open discussions with your physician. For all you consumers with spinal cord injury, have open discussions with your physicians about any type of supplements you're taking and nutritional products, because that again could have an interaction with your medications. Next slide. And this was another study out of the United States, and involving 28 spinal cord injury patients, and it was at a rural US academic rehabilitation center. And surveying this group, they found that 71% had tried chiropractic, 79% would recommend it, and 61% would use it. Then they further went on to get people's feelings about it using the Likert scale. And so that's a 1 to 7 scale, where 1, you absolutely disagree with the statement, and 7, absolutely agree with the statement. And we came with chiropractic, came in around a 4 out of 7. And that was asking the question that, is chiropractic a valuable method for resolving a wide range of musculoskeletal problems, not just back pain, but I would assume extremity and so pain and musculoskeletal problems then as well too. Next slide. And this one's from British Columbia, and it was looking at spinal cord injury and holistic health practices. So they surveyed 53 spinal cord injured patients, and they found that 87% of them had used holistic practices. Reason for using so was a desire to improve mental, emotional, and physical health. And what I think is quite important as well too is to provide hope, and that one can live a full life. So again, we all need hope, and so there's it's interesting that that was a reason for them to use. So and then also what they're recommending with this is for rehabilitation professionals to familiarize themselves with these different practices and their benefits for patients with spinal cord injury, because again, patients are using these services, and rehabilitation professionals should know the pros and cons of them in order to keep their patients safe. Next slide. And now this is a really interesting study looking at spinal cord injury and complementary therapies and rehabilitation. And this was done in the United States, and involved having occupational therapists and physiotherapists trained in using complementary therapies, and then using them with their traumatic spinal cord patients to see what type of results they had. And so the therapies that they were using included yoga, Pilates, Tai Chi, aromatherapy, relaxation techniques, and imagery then as well too. And an interesting result of this was that they had a greater reduction of pain severity at 6 to 12 months post intervention versus the control group. And they also found that there was less pain interference at 6 months after the intervention then as well too, which is good to see. Next slide. Now this study was done in Italy. So osteopathic practitioners kind of vary from country to country. In Canada, an osteopath is very similar to a massage therapist. And then in Italy, an osteopath, I think they're just recently regulated, osteopaths will perform like soft tissue techniques and so forth, along with spinal manipulative therapy that as well too. Whereas in the United States, actually, an osteopathic physician in the United States is no different than a medical physician. They can apply for any of the residencies in medicine and specialty residencies in the United States. So really, in Italy, there's, I guess, an osteopathic clinician would be similar to a chiropractor, or close anyways. And so they used a variety of techniques in this study. So myofascial release, that's where you use your fingers and you stretch out the muscle. And as you're stretching it out, you're using the fingers to kind of break down any type of adhesions in the muscle. Strain, counter strain, you sort of shorten the muscle and then hold it there for about 60 seconds or so until the tension relieves, and then you passively stretch it out. Muscle energy techniques is where you stretch the muscle and then the patient applies force in the opposite direction, and hold that for a count of like 15, and then relax and then stretch it further. And then cranial sacral therapies, I think, is just sort of a light touch therapy that's on the spine and so forth. I'm not too proficient in that, but that's my understanding of it. So with this study, they weren't using any spinal manipulative therapy, and the reasons for that was the potential for vertebral fractures, because there's a surgical fixation involved with the spinal cord injured patients, and also spasticity and flaccidity. And what it found, this was being used for pain management, and using the osteopathic manual therapy, they found it was a feasible approach in patients who available drugs could not be used. So again, in some situations, pharmacological approaches can't be used. And so this was found to be helpful with pain management with this group. And then also they found that using these osteopathic approaches with the existing pharmacological protocols were beneficial. So the two in combination were effective then as well too. So next slide. Now, a little bit of information on spinal cord injury and pain. And for all the spinal cord injury consumers out there, you know what I'm talking about. 70% of spinal cord injured patients experience persistent pain. And, pain has such an impact on people's lives. It affects your thinking. It affects your mood. It affects your activities of daily living and your quality of life. So, and it's very common. Musculoskeletal pain with spinal cord injury is common in both the acute and chronic post-injury phases. And factors for this being present, really, using your upper extremities so much for propulsion in a wheelchair, a manual wheelchair, being in a wheelchair, having a poor seated posture, spasticity. Again, we see at the mobility clinic, spasticity is a real problem for patients. And subluxation, I say that in the medical context of subluxation, where there's a partial misalignment of a joint, and that leading to problems. And then the injury itself causing pain. And so pharmacological approaches, the response may sometimes be limited. So again, that's where, again, other options may be a benefit. Pain also limits participation in self-care for patients with spinal cord injury and in other rehabilitative activities. So again, patients with spinal cord injury can't participate in their physiotherapy and their occupational therapy rehab because they're in so much pain. So if anything could be done to lower that pain, that would enhance the management by the physiotherapist and the occupational therapist then as well too. Next slide. And so talking now about team-based and collaborative care. And, really that's the future. And that's what we have at the Center for Family Medicine and at the Center for Family Medicine Mobility Clinic. And, patients do much better when you have a team of providers looking after them. And, not only family physicians and specialists, but also nurses, physiotherapists, and others. And that could include chiropractors. And where teams exist, patients have faster and easier access to care, the care that they need, fewer hospital admissions, they're much more satisfied, and also system costs are reduced. And this is from the Ontario Medical Association's prescription for Ontario, which was just released in October 2021. Next slide. So again, with chiropractic and collaboration, chiropractic services are being increasingly integrated into outpatient and inpatient multidisciplinary environments with a need or preference for including non-pharmacological interventions. So I think that's the niche that chiropractors bring to the table is non-pharmacological interventions, whether they be necessary or desired by patients. Next slide. Now, talking a little bit about chiropractic and neurorehabilitation hospitals, the first is from the physical medicine department at Walter Reed National Military Hospital in the United States. And this was a case report of where a patient had a traumatic brain injury. And as a result of that, they had ossification within their spine. And so what the chiropractor was providing in this case report was manipulation of the costovertebral joints. That's the rib joints. Now, they weren't performing spinal manipulation, but they were doing it on the ribs. And again, the reason for not using spinal manipulation on the spinal joints was a risk of pathological fracture or disc derangement. But they were doing it on the ribs. And they were also giving some breathing exercises, activation advice, in other words, encouraging participation in activities of daily living, and aquatic therapy. And again, I think aquatic therapy is fantastic. At the mobility clinic, we send a lot of people for aquatic therapy at the YMCA and so forth. And what they found with this case report, it improved respiration or breathing and pain. Next slide. And then here's another situation in a neuro rehab hospital in the United States, in Greenfield, New Hampshire, where they had chiropractic care. And it was collaborative management of an incomplete neck spinal cord injury after a motor vehicle accident. And what they were focusing on there with the chiropractor in this neuro rehab hospital was coordination between the physiotherapists and the other practitioners and the chiropractor to avoid redundant therapies. Because again, it's that old saying, too many cooks in the kitchen. There has to be coordination or else there can be trouble. And so they found that was helpful, and they found the chiropractic care reduced the pain and also enabled other rehabilitative activities by the occupational therapist and the physiotherapist, because again, pain was no longer a barrier to that participation. And again, this next point is critical medical clearance. So all the patients had medical clearance before receiving chiropractic care. And each spinal cord injury is unique because there's so much variability with the injuries. So again, it's not a homogeneous group, it's very heterogeneous. You see a lot of variability with the injuries. So you really need to have, on a case-by-case basis, have medical clearance to ensure that the patient is kept safe. The therapies that they were performing in this neuro rehab hospital, they did the soft tissue therapies 93% of the time, mechanical percussion, that's like a vibrator, 83% of the time, manual muscle stretching 73% of the time, and then they were doing some spinal manipulation and to the extremities manipulation as well too in 65% of the cases. And again, I'll talk later about the cautions you have to take as someone with spinal cord injury and or referring to a chiropractor for therapy with spinal cord injury, there are some concerns where you should not perform spinal manipulative therapy. Next slide. And then as far as expectations with chiropractic integrating into a rehabilitative setting, what they found, the stakeholders were, they were looking for pain management with patients by the chiropractor, collaborating with the team on functional improvements, and again, by improving musculoskeletal injuries, that would help with functional improvements. Working towards discharge then as well too. As all you spinal cord injured patients or consumers know, again, when you're in the rehabilitative hospital, they're really geared towards discharge, setting goals and working, towards it. And it's happening much more rapidly than what it would have, say, 30 years ago. I worked at Lyndhurst Hospital as a medical attendant in chiropractic college. And that was sort of my first exposure to spinal cord injury. And there, patients would stay like 6 to 8 months. And now it's a fraction that time that patients are spending in the rehab hospital. And then whole person healing, again, chiropractic has a holistic approach, so that can be beneficial towards whole person healing. Again, integrating within the team, finding your niche within the team was critical. And again, making sure the chiropractors weren't spending any time trying to improve muscle tone, either spasticity or laxity, because the literature just doesn't support therapy being directed towards that. Next slide. And then qualities for a chiropractor that's on a multidisciplinary team. You want them patient-centered. And again, that's having the patient as an active participant in the process. So that's the best way to approach things. Professional qualities as well. You want a safe practitioner that's on top of their game and uses effective treatments. Interpersonal qualities, again, you want a practitioner with emotional intelligence and some connections, coming from the same hometown or whatever, or connections with these patients and so forth, and comforting. Interprofessional qualities, open to feedback and a team player. And organizational qualities, again, really fitting in with the mission of the hospital and the rehabilitation team. Next slide. So what to expect with a chiropractic visit? So typical chiropractic visit, initially you'll fill out some intake forms, and that it'll go through all the major systems and surgeries and medication and so forth. So having all that information, the chiropractor will review before you're being seen, just to give them a sense of the full health history of the patient, and then taking a focused patient history after that. And again, talking about the type of pain and how long you've had the pain and whether it radiates and so forth. And are there any red flags present, like a history of cancer or something like that. And then with the history, that information is used to guide an examination, having a focused examination, and where you'll do a series of orthopedic tests and chiropractic tests and so forth. And that will then, with that information gained from the patient history and the examination, you come up with a diagnosis or a working diagnosis. And at that point in time, it's communicated to the patient. And then, sometimes on the first visit, you'll just go through those initial 4 points. And then on the next, or, pending how the chiropractor is, or they'll either do it over 2 visits or 1 visit, and then they'll have the informed consent. So again, describing the diagnosis to the patient, what treatments are recommended, and the risks of those treatments then as well too. Treatment will also include patient education, some self-management, exercises and so forth, and it may involve some type of manual therapy if that's deemed safe then as well too. Next slide. So chiropractic treatment. So again, chiropractic care is more than just spinal manipulative therapy. a chiropractic adjustment or spinal manipulation, it can be done in 2 minutes and you're done. So typically, care will involve more than that. And it's usually some type of education and self-management and a combination of active therapy where you're giving exercises to the patient that they can do at home, and then some passive therapy then as well too, where you're doing the manual therapy on them or using some type of modality like ultrasound, interferential current, and so forth. The most forceful thing we use is spinal manipulation. And just for myself, I haven't used spinal manipulative therapy on the spinal cord injured population up to this point in time. And so I feel as a chiropractor, we have a number of tools in our toolbox. And just for me, I've kind of held off on that. And I'll explain that why a little bit later. Maybe in some cases it is safe, but you should have medical clearance for that. So just to let you know what I'm thinking with regards to that. And to me, chiropractic is more than just an adjustment. It's, the exercise and the self-management and other services that we provide. So we have more than one tool in the toolbox. And so that would be the type of, chiropractor I would recommend you search out. Next slide. So spinal manipulation, essentially what you're doing with spinal manipulation is you're putting the body in a certain posture and stretching it out, and then you apply a thrust. And what that does is it is a very focused stretch when it's done on the spine to tight regions in the spine. It loosens up the spine. Sometimes you hear a little bit of a cracking sound, and what that cracking sound is just gas being released from the joint. The spinal joints are very similar to finger joints. So if you've ever cracked a finger joint, what you're doing there is you're separating the joint surfaces, and there's a lubricant within the joint called synovial fluid, and dissolved within that is nitrogen gas. So when you separate those joint surfaces, it creates a negative partial pressure, which draws that dissolved nitrogen gas out of solution and causes that cracking sound. So it's not really the cracking that gives the benefit. That's sort of a byproduct of the thrust. It's that thrust that specifically stretches out the tight tissues and enhances the range of motion within that tight region in the spine. And it can be done either by hand, or it can be done with an instrument then as well too in some cases. So next slide. And so how spinal manipulative therapy works in non-spinal cord injured patients. So what we were taught back in chiropractic college, it's evolved more since then. It's called the gate theory of pain control. And that's where you're using mechanoreceptors within the skin that go on large nerve fibers that then at the spinal cord level cause inhibition of C fibers, which are involved in pain transmission. So the physiology is much more advanced than that now. Pain science is a huge science. And so I don't claim to be a physiologist or anything like that, but essentially you're using that stimulation from the manipulation to then block propagation of pain signals to the brain. And then there's also, potentially, there could also be some other mechanisms going on there with inflammatory responses. There's still more research being done on that. And all the references I have at the end of the presentation. Next slide. Oh, actually, just to show you different types of spinal manipulation. On the left there, you'll see where they're doing a neck adjustment. That's sort of a typical neck adjustment they do on people, without spinal cord injury. And then in the middle slide is where they're doing in the mid-back. And then the slide or the picture on the right is showing how they do a low back adjustment. And then on the lower left, that's an instrument manipulation, just to show how that's done in the mid-back area then. Next slide. So does spinal manipulative therapy work in non-spinal cord injured patients? There was a Cochrane review in 2011, and they found that it's no better or worse than exercise, standard medical care, or physiotherapy, and this was done across 6,000 patients. What they did find with spinal manipulation is that it had some statistically short-term benefits on pain and function. both when by itself or when added to other interventions, and there weren't any serious complications in any of these trials. So with all this research that I'm talking about spinal manipulation, it's with non-spinal cord injured patients, because it's such a small group that it's tough enough to do research on a large group with spinal manipulation, let alone doing it with a smaller niche group like patients with spinal cord injury. But this is the information I'm presenting on non-spinal cord injured patients. Next slide. So again, spinal manipulative therapy with non-spinal cord injured patients. It's recommended by the American College of Physicians guidelines for low back pain. And again, as I said here, extreme caution with spinal cord injured patients, and I'll talk about that shortly. Next slide. So risks, again, for non-spinal cord injured patients. Common risks with spinal manipulative therapy: you get an aggravation of symptoms, muscles, ligaments, strains, sprains, muscle spasm. In rare situations, you'll get rib fracture or irritation or aggravation of a vertebral disc complaint. And then extremely rare, you'll have cases of a stroke. And what that's caused by is a vertebral artery dissection in the neck. Again, it's very rare, and but that can happen with neck adjustments. And then also with, you get a condition in the low back called cauda equina syndrome, and that's where you have the nerves to the bowel and bladder are affected, and that's a medical emergency to get that dealt with. But again, both those are rare. Next slide. And then possible contraindications to spinal manipulative therapy. So in any patient where you have progressive or sudden neurological deficit, contraindicated. Presence of spinal cord tumors with neurological compromise and requiring medical intervention, contraindicated. So again, many spinal cord injured patients should not have spinal manipulative therapy. Chiropractors are aware of the general risks of spinal manipulative therapy, but again, most chiropractors have limited awareness of the other specific risks of spinal manipulative therapy with spinal cord injury, and I'll talk about those on the next slide. So you can go to the next slide. So again, that's why you have to have medical clearance for seeing a chiropractor. And again, that's where collaborative practice works best, where the physician can send information to the chiropractor so they know exactly what they're dealing with, and the physician can express any concerns they have, what treatments to do, what not to do. And so again, the reason for this is, again, the spinal cord injured population is so diverse. There could be a cervical spine injury, a lumbar spine injury, so incomplete, complete. So there's challenges with that. So that's why it's really important to understand. A chiropractor needs to know what they're dealing with and have the specifics of the injury. Is a wheelchair required? Does the patient need assistive devices or bracing? Are they ambulatory? Can they walk? Are they independent in their transfers? Is it a complete or incomplete injury, like I said? And then other considerations to include, from a safety sake, you can have what's called a spinal cord syrinx, which is like a fluid-filled region within the spinal cord. And again, any type of spinal manipulation with that present could put some traction on that, and that could lead to problems. Also, does the patient have autonomic dysreflexia? So people with an injury at the T6 or higher level are at risk of getting autonomic dysreflexia. And so therapy by the chiropractor could be a trigger for them having an episode. And that's where you get a big spike in blood pressure, and the patient gets flushed and is anxious and so forth. And so again, we don't want to set off an episode of that with treatment. Is there any contractures or spasticity assisting the patient's function? So again, sometimes there's tight muscles and tight regions in the spine or the joints, and that's actually beneficial to the patient to function. And so as a chiropractor, you don't want to go in there and be working on areas that are actually helping the patient to function. So again, that would actually not be of benefit to the patient. Again, you want to make sure that the spine is stable, again, that all the fractures have healed, the instrumentation that may be in the spine from the injury, the hardware is all stable. Also, a big problem with people with spinal cord injury is osteoporosis. So again, if a chiropractor is doing any spinal manipulative therapy with osteoporosis, there's a risk of a pathological fracture. There could also be tethering of the spinal cord then as well too. So again, any type of manipulation with a tethered spinal cord could result in a traction injury to the spinal cord. And then being on blood thinners too, if the chiropractor is really aggressively working on the patient and they're on blood thinners, there could be like a hematoma and bruising and other problems. And then other considerations, again, the patient may need to be treated in their wheelchair or treated at their home. Typically, chiropractic tables are narrow, and so that might be too narrow for a patient with a spinal cord injury to safely negotiate. So that's where a wider physiotherapy plinth would work better than a chiropractic treatment table. Next slide, please. As far as optimal dosing with spinal manipulative therapy in non-spinal cord injury, typically they say about 12 visits. The research and the literature supports 12 visits typically is after that you get more limited benefit. And so setting a cap on treatments of 10 to 12 visits seems reasonable. And I always say, within 4 to 6 treatments, I'd like to see 20 to 30% improvement to justify carrying on. And really in the back of my mind, I'm thinking, 2 to 3 treatments, I like to see things improving. But definitely by 4 to 6, if I'm going to be effective, I should see some improvement within that period of time. And then you hear a lot about chiropractic and maintenance care or supportive care. And there was one small random control trial done by physicians that were doing ongoing spinal manipulative therapy, and that seemed to have some benefit to it. So how I liken to that is, someone working on a computer. You're working on a computer 40 hours a week, and then you go to the chiropractor and they kind of loosen you up and reduce your pain. And then you go back to that computer and you're doing another 40 hours a week. So again, the cause of the problem has not been removed. So in that case, I can see a justification for periodic maintenance care to kind of support the patient to kind of optimize their function. Next slide. And now this is the technique that I use on my spinal cord injured patients the most, and what I found is most beneficial. It's called trigger point therapy. And this was developed popularized really by Dr. Janet G. Travell. And she was the personal physician to President Kennedy. And she mapped out every muscle in the human body, every trigger point, which is like nodules within a muscle, and where that pain would refer to with every major muscle in the human body. And so she put that into the classic textbook, Myofascial Pain and Dysfunction, the Trigger Point Manual, and it's still popular and in print to this day. I've got copies of it. Once a month I go to it just for clarification to see if that could explain some of a patient's pain. Next slide, please. So again, that's all to do with myofascial trigger points. So the picture on the right there shows you that it's the trapezius muscle and a shoulder muscle and goes into the neck. And the X's show you where the nodules are, or the trigger points. And so those painful nodules refer to where the red goes. So this would be a situation where possibly in some cases, what you might think is neuropathic pain with a spinal cord injury is actually coming from these trigger points, not necessarily, but possibly that's the cause of it. So again, with different muscles, you'll get different referral patterns and so forth. And again, she mapped out the entire body. How you treat that is with your hands, you apply direct pressure to that muscle and you sort of squeeze the muscle for about a minute. And then over that minute, you'll slowly kind of feel that nodule of tight muscle dissipate. And it's like the muscle kind of melts away in your hands. And it's a little uncomfortable when it's done. So here's the challenge with the spinal cord injured patients. You may not have sensation to where the the chiropractor is doing the trigger point. So where you have sensation, as a guide, I would use on a scale of 1 to 10, I'd say like a 4 to 5 out of 10 for pain, where you're applying the trigger point. And so that would be safe and or is tolerated by the patient. And again, you have to be a little more cautious with a patient with a spinal cord injury, especially if there's low sensation, so or diminished sensation. So I would err on the side of caution. And again, with this, you should have medical clearance as well too, just because again, triggering autonomic dysreflexia, if they're on blood thinners, it could cause bruising. And again, that trigger point might be assisting their function. So again, it might help them use their partially used arm function. So again, you want to make sure that you're not doing trigger point therapy on a trigger point that's actually beneficial to function. Next slide. And again, the picture on the right there, it just kind of shows you within the muscle, it sort of shows how normal fibers are. Then you get these little nodules within the muscle fibers. And that's when you're applying the pressure, you slowly kind of cause that to dissipate and then kind of be more homogeneous after the treatment is done, what you're hoping for. So now still with myofascial therapy, much is not fully understood. In addition to that manual therapy technique, that squeezing technique that I use, stretching and strengthening are of benefit. The literature says that that manual therapy of treatment for the trigger points is maybe as effective as dry needling, which is another type of technique similar to acupuncture, and large quality studies are lacking. Next slide. And so home exercises, that's another big thing that I do. So again, giving a custom exercise program to a patient, again, medical clearance that it's safe for them to do so, and then giving stretching and strengthening exercises. Also, what's great, as I said earlier, was the aquafit or pool therapy. The wonderful thing about pool therapy is that gravity is removed. So if you have partial function of a limb, or your muscle strength is diminished, when you're floating and gravity is removed, you might be able to get that full range of motion and strengthen that muscle, whereas that wouldn't be possible with gravity on land. So aqua therapy is wonderful. Now, of course, with COVID right now, the pools are temporarily shut down, but I think things should open up again soon. Another program that I really like that's locally here in Kitchener is the YMCA NeuroFit program, and they may have that in other regions of the country or wherever you're at. You could check with the YMCA, and that program is geared for people with multiple sclerosis, Parkinson's disease, stroke, and spinal cord injury. And what they kind of focused was on all the commonalities of those conditions, and then gearing an exercise program to those people. Part of it land-based, part of it pool-based. And then SCI Action has got some great guidance for exercise for people with spinal cord injury. Again, starting out doing strength training twice a week, aerobic training twice a week, and then the advanced level, you increase the aerobic training to 3 times a week. Again, you should always get medical clearance with that. And again, don't ease into it with exercise. The key is ease into it. If you go gung ho, you'll be sore for a month, and then you won't be able to carry on. So it's always good when you're starting something, you ease into it over a few weeks to a month, and that'll make it be as positive experience as possible. Next slide. So indications for referral to see a chiropractor. Again, you want medical clearance, mechanical, non-specific back pain, no identifiable pathology, no red flag, so tumor, fracture, infection, cancer, serious medical condition. And again, the conservative care is in line with the patient's values. Next slide. And again, practice tools for non-spinal cord injury patients. So this is for any medical professionals in the audience. There's manual therapy as an evidence-based referral for musculoskeletal pain, and that tool is from the Center for Effective Practice. And it's, again, a primary care provider focus. There's also management of chronic non-cancer pain, Center for Effective Practice. That's primary care provider focus. Both recommend chiropractic manual therapy as appropriate, and possibly these could be used as a guide for referring spinal cord injured patients. And next slide. And that just kind of shows pictures of what the tools look like. The one on the left is the manual therapy one, and then the one on the right is for chronic non-cancer pain. Next slide. And then as far as coverage and fees, 90% of extended health plans cover it. Workers' comp and motor vehicle accident claims, at least in Ontario, are covered. Recently, or actually not so recently now, family health teams and nurse practitioner clinics can also have chiropractic services if they so choose. And the Ontario Chiropractic Association for cash patients recommends around $40 a visit. It'll be a little bit more for an initial visit. It might be $80 for an initial visit, and then $40 for follow-up treatment. But of course, compassionate reductions are common. And so again, a lot of patients, if money is tight, you treat for $10 or something like that. So if money is tight, talk to your chiropractor about that, and most are willing to kind of bend there a bit. Next slide. So as far as practice variability with chiropractics, a good example would be, in the recent past, physician opioid prescription. There was variability with that. Well, there is variability with chiropractors. So the research and literature tells us that physicians are often uncomfortable recommending any chiropractor. So as a physician, for the physicians in the audience, you have certain physiotherapists that you like to refer to. Again, you have to develop this trusted referral network. So there are chiropractors in your community that you can deal with. You just have to go out there and find them. You have to be a bit of a private investigator and ask the right questions, but it can be done. And make sure they align with your expectations. And then, send a referral note to the chiropractor by the physician about what therapies you expect and what to avoid then as well too. Next slide. And typically I send a consult report with any medical referral or when requested by the patient. And I do a typical SOAP note. So like the subjective, what the patient reports, objective, what I found with my examination, the assessment, that's sort of your diagnosis, and then the plan, that's your plan of management. And I try to keep it to a half a page and identify red flags, and maybe I'll request imaging. If imaging has been done that's identified by the patient, I'll request it just so I have a better understanding of what I'm dealing with. And it's an opportunity for collaboration. And again, the benefits, I try and protect the physician. So if a physician refers me a patient and I see something that's concerning, I bring that to the physician's attention to protect them. Next slide. So how can chiropractors help the system? So the value we offer to other providers is we have the time to focus on the specific problem. Again, we're not the fourth complaint in a 10-minute office visit. We have like the luxury of, a half hour, an hour to focus on that specific problem. We take a non-pharmacological approach. Again, provide patient education, do's and don'ts, self-management, exercises, and so forth. And we can also act as far as facilitating coordination of care with other complementary providers. Most chiropractors are more knowledgeable in navigating complementary and alternative medicine. Next slide. So thank you. And I've got my email at the bottom there as well too, if you have any questions you want to send by email. But right now I'd open the floor to questions.
Great. Craig, thanks so much for just an excellent overview of both complementary alternative medicine and chiropractic, which, I think a lot of people don't know about. So, that was great. I did have a question, and you sort of touched on it at the end, but, a lot of people, maybe just reiterate what people should look for if they're looking at obtaining a practitioner, because as you know, like, people with spinal cord injury are always facing people who don't have levels of expertise or lack training. Can you kind of comment a bit on what is the typical training towards a spinal cord injured patient in chiropractic college, if any, which would be similar to most professions.
Yeah.
And then, how does the patient then sort of, do they kind of interview their chiropractor as such, or, what are the questions to ask type of thing, if you maybe just reiterate that.
Yeah. So what I would recommend, again, you want someone that takes an evidence-based approach. And again, this is where you have to be a little bit of a private detective, and find out what approaches they use. And again, someone who's reasonable with the number of times they'll see you. So, that keeps it to within those 12 visits and so forth. Or there are some situations where you have to see patients more often than that. Like a traumatic motor vehicle accident, but for just your typical back pain or whatever, 12 visits should cover it. And again, I think just like with a physician, really, spinal cord injured patients kind of have to train their physician about what is required in their care. So it's the patient expert. So the patient has to be the expert in their care in many cases to guide a physician. And you have to be that expert again as well, and to guide your chiropractor. So, again, I would say look for someone that does trigger point therapy and so forth. And I do a lot of it, and it gets great results. Someone who gives exercises, therapeutic strength and stretching exercises, and if you can, through your network, the people with spinal cord injured are often highly networked with other people with injuries, so, and if not, then, going through an organization like Spinal Cord Injury Ontario, where you talk to other patients or consumers with spinal cord injury and find out who they're using. So talking to someone else who had a positive experience with a chiropractor, that's probably a good place to start then as well too. And again, someone, when a chiropractor is just doing spinal manipulation, that's sometimes that can be like a 2-minute appointment. Well, you don't want someone that spends 2 minutes with you. You want someone who spends a bit more time with you, who can do the soft tissue therapy and so forth. So that's, and again, as I said, the risks of spinal manipulation with spinal cord injury, with the osteoporosis and the pathological fracture, and then autonomic dysreflexia episodes. So that's being the patient expert and kind of, guiding the practitioner, but then also starting with someone who you can work with, who's recommended by another person with a spinal cord injury or another family member who's had a good experience, and, gives exercises, self-management, and doesn't, sign you up for 3 times a week for 6 months or whatever, but is reasonable with their treatment recommendations. I hope that kind of helps.
Yeah, that's great.
Dr. Craig, I have a quick question.
Yes.
As a patient with spinal cord injury, how do I know, how am I an expert? How do I know what questions to ask?
Well,
is there a manual of all the questions that I should ask, or how do I?
It's just what I was saying, that what we found at the mobility clinic is that, again, like with physicians, is that the patient often knows some things the physician doesn't and can guide the treatment. Would you say that's kind of correct, Jamie, in some circumstances?
Yeah, well, for sure.
Yeah,
Lots of circumstances, they
yeah.
often know way more and better than us.
Mm-hmm.
Yeah.
I
But
mean,
there might be things that they miss.
Yeah, so that's where, so again, what I would recommend, playing it on the safe side, look for a practitioner that does soft tissue therapy, who does, just say, I have a spinal cord injury, so I'm uncomfortable with spinal manipulation. Could you do some like soft tissue therapy or like that trigger point therapy on me where it's required? And also, can you give me some specific exercises and some stretching and so forth as well too? And if we could do it on a trial basis, maybe try, 4 to 6 treatments just to see if it helps. And if it does help, I'll continue. But if it doesn't, then maybe this isn't a good fit for me. So that's what I would kind of recommend people do, if that seems reasonable.
But you still need a medical approval, right? You still
I
need
would,
someone.
it'd be nice, like, I'm used to working on a team. So, so again, and sometimes, asking your physician, ask your physician, who do they recommend, and they'll know, well, these guys are reasonable and you can deal with this chiropractor. And what I'll do is I'll send a referral note to the chiropractor, say, okay, it's okay if you do this with the patient, but what I don't want you doing is doing this. So, if you can work with your physician to say, just say, look, I'd like to give chiropractic a try. Can you give me some guidance as to what I should have done or not have done?
Okay, thank you for that.
Just because, again, like all the research in chiropractic is done with people without spinal cord injury. So, I mean, even that research is not as, I mean, it's getting better, but it's not quite as plentiful as we would like. But for it's much less than for, I mean, it's almost non-existent with spinal cord injury patients. Basically, you saw every published paper on spinal cord injury and chiropractic that's out there.
Hi,
Oh, yeah, go ahead.
yeah, my name's Guy and I have a spinal cord injury.
Yeah, yeah.
And when you talk about medical clearance and having that from a family physician, or are you talking from a physiatrist and that specializes in spinal cord injury? Which
A
would-
physiatrist would be great. If you could get, because a lot of physiatrists are familiar with chiropractic, and they could guide what treatments to do and what not to do. So if you have regular checks with a physiatrist, next time you see the physiatrist, just say, hey, I'm thinking of seeing a chiropractor. Can you write a letter to the chiropractor about what to do and what not to do, to kind of give them some guidance? That'd be ideal. So, physiatrists, most physiatrists have a pretty good idea about chiropractic. Whereas a family physician, that's better, that's still good. Maybe not as good as a physiatrist. Unfortunately, most people don't have regular contact with a physiatrist, so they'll be dependent upon a family physician to kind of give that guidance. But I still think that guidance is important, because they can give more specifics about the injury to the chiropractor.
Thank you.
And maybe that family physician says, hey, I know this guy, and they're reasonable, and I'll send a letter to guide them about what to do and what not to do, and see these guys. So that's what I would do.
Great. Well, maybe just because we're at our time limit, maybe I'll stop things there. Dr. Bauman did leave his contact at the end of that slide. So if people do have questions, I'm sure he'd be more than willing to answer them offline as well. I want to thank Dr. Bauman for just an excellent presentation and for his time and expertise. And I also want to thank everybody for attending. Especially, and we continue with these webinars, so we're planning to have one in another few months, so have a look out for that. We also encourage you to share this stuff broadly with your networks and friends. This isn't an exclusive club. We'd love to have lots of people involved, so feel free to share. And also, if you can, if you feel that there's a topic of interest, please email us back to the contact email that you would have, and let us know if there's something that you specifically like to hear. And with that, I'll say bye to everyone, and thanks again to Craig, and everybody have a good day.